So there is a ipsilateral anosmia and ipsilateral optic atrophy along with contralateral papilledema. Where do you get this combination basically? It is called as Foster-Kennedy syndrome, which is because of a meningioma which happens in the olfactory groove or a sphenoid ridge, and there is a ipsilateral anosmia, optic atrophy and contralateral papilledema is what you need to basically remember. Now the anterior cerebellar artery is involved, and what are the important structures that are showing the lesion in this given case? So it's a classical case of Millard-Gubler. Very recently when we discussed DNB medicine, we discussed all these things in the finest detail. So what is the combination Millard-Gubler? It involves ventral pons. Third, fourth are there in midbrain, cranial nerve. 5, 6, 7 pons. 8, 9, 10 everything medulla. That is what you need to basically remember. So that is the reason ipsilateral facial paralysis, 7th nerve, ipsilateral lateral rectus, 6th nerve, and contralateral hemiplegia, because that is a point where corticospinal tract is coming, passing through brainstem, still it is unmarried, it didn't cross. After reaching medulla, it will cross and go to opposite side. So the combination is called Millard-Gubler. Now what are the symptoms of the patient? Paralysis of the gaze, ipsilateral lateral rectus paralysis, ipsilateral facial nerve palsy, and anterior cerebellar artery involvement. So, or superior cerebellar artery involvement. What is this condition basically? It is called Foville's syndrome. So Foville is because of the problem in the pons, but in tegmentum, not in ventral pons. See, basically midbrain and brainstem structures have one roof and one floor, tectum, tegmentum. So involvement of tegmentum of the pons is responsible for Foville. Ipsilateral facial palsy and contralateral hemiplegia, and there is also internuclear ophthalmoplegia. Why? Give me the board. We are now going to talk about something, a coordination that will occur between two layers, midbrain and the pons. In the pons, you are having the 6th cranial nerve nucleus, and in the midbrain you are having oculomotor nucleus, which is 3rd. So your eyes are looking, let us say, towards this side. Your which eye you call this as? Right eye. Right eye, left eye. If the right eye is undergoing abduction, your 6th cranial nerve nucleus is responsible for making your right eye to abduct. But for your right eye, when it is abducting, the left eye should undergo, assume this is the nose, left eye should undergo adduction for you to look to, can you give the projection, for you to look towards right. Your right eye should undergo abduction and left eye should undergo adduction. So your 3rd cranial nerve should make the left eye to undergo adduction. So who will tell that the right eye is abducting to the left eye's 3rd cranial nerve nucleus? There must be some connection between these two, and that connection is called as medial longitudinal fasciculus. What does it connect? There is an area called PPRF, peripontine reticular formation. A part of the reticular formation is in the pons, which is from where this medial longitudinal fasciculus is taking origin, and it connects the 6th cranial nerve nucleus with the opposite side 3rd cranial nerve nucleus. So if there is any problem in case of Pupillary syndrome to this peripontine reticular formation, then whenever the one eye is abducting, the other eye cannot adduct. That is the problem that the patient will have. And whenever this abducts but it did not adduct, what will happen? This is looking this side and that is looking straight. So the image become two, double image, diplopia will occur. So to compensate that, immediately this abducting eye once more comes into quick nystagmus. So you have a eye with nystagmus and you have an eye with adductor lag. And the side where the eye is showing adductor lag, it is that side where the medial longitudinal fasciculus is considered to have the lesion, is what you need to remember. So Pupillary is a combination of what? Problem in the pons. That is the reason peripontine reticular formation leading to internuclear ophthalmoplegia along with the seventh nerve palsy, because it is this pons where the seventh nerve is there, along with contralateral hemiplegia. The combination is what you basically come across. Very happy to see Manoj, Rosaline and many more new students. So doctor, superior oblique muscle, superior rectus muscle, all these are passing. Then what is that fissure called as? It is basically called superior orbital fissure. If there is any lesion there, what are the problems that will come? There will be a pain and sensory disturbance in the fifth cranial nerve distribution, ipsilateral ophthalmoplegia because of the oculomotor, trochlear abscess, all the three get affected, and oculosympathetic paresis will be there. So the combination is basically called superior orbital fissure syndrome, is what you need to understand. Now, if you look at this hypoglossal nerve can have a lesion in the nerve, or it can lesion in the medulla. Medulla is the place where the nucleus of it is located. Then there are some fibers coming from the opposite side and ipsilateral side called corticobulbar fibers. Just like your anterhorn cells in the spinal cord are controlled by your corticospinal tract, which is a pyramidal tract, the cranial nuclei are controlled by corticobulbar tract. But anterhorn cells are controlled only by contralateral corticospinal. But cranial nuclei are controlled by both ipsilateral corticobulbar and contralateral corticobulbar also. So when do you call upper motor neuron palsy? If there is any connection coming from the brain to the nucleus get interrupted. In case of anterhorn cells, even if corticospinal tract one side cut also, the opposite side will get what? Upper motor neuron type of weakness. But in case of cranial nuclei, unless both sides corticobulbar are being cut, then only you will get upper motor neuron type of clinical features for cranial nuclei. That is the difference between cranial nuclei and anterhorn cells. Okay, doctor? So there is the lesion. It all depends where is the decussation. So suppose if the lesion is involving the level A, tongue will be deviated contralateral, and B, it will deviate ipsilateral, and C, it will also deviate ipsilateral among the levels A, B versus C is what you need to remember. So basically you need to know what is UMN and LMN in that given scenario. Now you have the glossopharyngeal nerve. Then in the course of the glossopharyngeal nerve there is a lesion at one particular point. So if for that lesion, what are the features that you come across? So what you will basically have is when a glossopharyngeal is involved, a hoarse voice, dysphagia, loss of gag reflex, but contralateral deviation of the tongue is a feature when which lesion occur? Hypoglossal nerve is the one which is basically involved. Then what are the various structures which are being shown over here? So fundamentally, based on the clinical features, you know that it is pons, pontomedullary junction, and structure A is superior olivary nucleus and inferior olivary nucleus, and B is medulla and C is pyramids. Fundamentally, the cut section shown to you is medulla, not pons. So in medulla you have a inferior olivary nucleus. Now tell me, what is the function of inferior olivary nucleus? So doctor, basics of neurology terminology. You have a medial lateral lemnisci, medial lemniscus, lateral lemniscus. You have a superior colliculus, inferior colliculus. You have medial geniculate body, lateral geniculate body. You have a superior olivary nucleus, inferior olivary nucleus. What are these structures? In neuroanatomy, you should know. First, what is medial lemniscus? Who will tell me? What is medial lemniscus? Medial lemniscus is a continuation of dash. What is the dash? Fill up the blank. Medial lemniscus is a continuation of dash. What is a dash? Come on, doctor. You attended neurology so many times, and yeah. Huh? You know dorsal columns? Dorsal columns. Dorsal columns carry what? Position and vibration sense. Right now? Let us see. Online students, anybody answer? Anybody answer? Dorsal columns carry position and vibration sense. They reach lower medulla. At lower medulla they undergo decussation. And where are they journeying to? They are journeying to thalamus. And from thalamus they become relayed to reach the sensory cortex. So between lower medulla, where they decussated and are going up towards thalamus, in that path it is called as medial lemniscus. So medial lemniscus is continuation of dorsal columns. After decussation they continue up to thalamus in the form of medial lemniscus. Khatam. So where is medial lemniscus? Medial lemniscus is dorsal columns continuation. Now what is lateral lemniscus? Typically in the auditory pathway, what is the meaning of lemniscus basically? Lemniscus क्यों बोलते हैं? Because knee joint has a meniscus. Why do we call lemniscus? In any sensory pathway, you have first order neurons, second order neurons, third order neurons, right? All sensory neurons first need to pass to reach the thalamus. That is the rule. Right? Except olfaction, visual pathway, auditory pathway, pain and temperature, vibration, position, all sensory pathways have to invariably reach thalamus. From thalamus they will be broadcasted to reach the sensory cortex. So from thalamus to sensory cortex you call it as what? You call it as third order neuron. Okay? If you take the dorsal columns come uncrossed until where? Lower part of the medulla. There they undergo decussation and at medulla, up to medulla it is first order, from medulla up to thalamus it is second order, from thalamus to sensory cortex it is third order. So the second order neurons of the dorsal column are called as medial lemniscus. Always lemniscus contain which order neurons? Second order neurons is what you have to basically remember. Similarly, in the auditory pathway, second order neurons, auditory pathway also will go to first to thalamus, then auditory cortex. Second order neurons in auditory pathway constitute lateral lemniscus. Got the point? Then what are colliculi? At the level of midbrain, when the pathways are ascending up, they have one station. Hyderabad, Nagpur, Delhi. So like that Nagpur like station, Bhopal like station is there, which is colliculi at the level of the midbrain. Superior colliculus is involved in seeing. Inferior colliculus is involved in the auditory pathway. Superior colliculus sustadi, inferior colliculus intadi. Okay. So colliculi, what will they do? Superior colliculus is involved in the visual pathway. Inferior colliculus is involved in the auditory pathway. Then you have two bodies, geniculate and lateral geniculate and medial geniculate. They are also almost at the level of the midbrain level. So where are they involved? Our eyes are medial, but lateral geniculate body is there in the visual pathway. Our ears are lateral, but medial geniculate body is there in the auditory pathway. Khatam? Then you have two olivary nuclei. So superior olivary nucleus, once more you will come across in the auditory pathway. But inferior olivary nucleus, what is the function of it? Inferior olivary nucleus is there at the level of the medulla. Medulla. If you take medulla, pons and midbrain, can online students can punch whether they can see the board? The board is only to align you from not losing the focus, otherwise we are not drawing much artistic on the board. It is a common ground of football playing between teacher's mind and student's mind. So you are having medulla, pons, midbrain. On the side of them you are having cerebellum. The cerebellum is connected with midbrain, pons, medulla with three peduncles called cerebellar peduncles. Superior cerebellar peduncle connects cerebellum and midbrain. Middle cerebellar peduncle, pons and cerebellum, and medulla and cerebellum are connected by inferior cerebellar peduncle. So cerebellum and medulla should talk to each other. Why they need to talk to each other? Because medulla is part of brainstem. All ascending sensory pathways are passing through it, and medulla is also having the vestibular nucleus that controls the balance. Cerebellum also controls the balance. So there must be continuous talking between the two that should happen. So what God has done is, for talking you require one mobile phone. No? So what is that mobile phone in the medulla which can communicate with the cerebellum? You have the inferior olivary nucleus. Inferior olivary nucleus receives the information coming from spinal cord, receives the information coming from vestibular nucleus, etc., and in turn it will be talking to cerebellum and receiving any information whatever that it received, it will keep telling to cerebellum. So that is how the coordination carries on, is what need to be remembered. So doctor, one evening is not enough for neurology, right? But we are teaching bits and pieces depending upon the type of question. So don't say, sir, why are you running so fast? Anatomy to medicine.com, neurology. And anatomy to medicine.com, neuroanatomy, there is a folder. You have full videos. Relaxedly we discussed, picking up one structure and telling what they are doing, blah blah blah. So I don't think you will have time, but if you have time, you can always go through those videos. So doctor, that is the story. Now let's talk about this. So you must know what is the pathway in the anatomical course of facial nerve. You have one solitary tractus nucleus, tractus solitarius. What is the speciality of it? For 3 cranial nerves, it is a common sensory nucleus. What are they? Nucleus N is 9th. Solitarius, S is 7th. Tractus, 10th. For 3 cranial nuclei, it is a common sensory nucleus. Geniculate ganglion, greater superficial pituitary nerves, sphenopalatine ganglion, they are the various structures which are involved in the anatomical course of facial nerve, is what you have to basically understand. Now doctor, where is the lesion? When something touches your cornea, then your eyelids close. Which cranial nerve nucleus responsible for the closure of the eyelid? 7th, right? 7th. Which cranial nerve nuclei for opening of eyelid? Come on. 3rd. Levator palpebrae superioris elevates the eyelid. 7th cranial nerve nucleus closes the eyelid. That's the reason whenever patients get Bell's palsy and 7th nerve palsy or facial nerve palsy, what will happen to their eyelid? Closure of eyelid doesn't occur. So there is an exposure keratitis to their cornea. Okay. So whenever you touch with something, one particular eye, the trigeminal will sense it and it will tell both the eyes to close the eyelid. It is not just only that eye which you are touching will not close, both the eyes will close, right? So if there is any one side facial palsy, only that eye closure will have problem if you touch it, right? But if there is a problem in the trigeminal which is afferent, then what will happen? That eye closure doesn't occur if you touch, even the opposite eye also doesn't close if you touch one eye. समझ में आया नहीं आया? मैं कुछ बात कर रहा हूं, आप कुछ सोच रहे. चलो मैं बताता हूं, मुझे समझ में आता. Without whiteboard, our brains will not coordinate with each other. It is like a radio tower. हमारा वो रेडियो वाला टावर से रहता ना, वो टीवी टेलीफोन टावर. It's a common link between my brain and your brain. Now doctor, if you touch this, मैडम आपके लिए हम दूसरे बार फरमा रहे हैं. If you touch the eye, what is sensory supply of this eye? Trigeminal, 5th cranial nerve. So the 5th cranial nerve will go and tell 7th cranial nerve to close both the eyelids. when if one eye is touched, fifth cranial nerve will go and tell both the seventh nerves to close the eyelids. इसलिए अगर फिफ्थ क्रेनियल नर्व को कुछ हो गया और वो आंख को आपने टच किया, then this afferent is blocked. So if you touch the eye, there is no information going to brain that this eye is touched. So this side, that side, both sides cranial nerve, seventh cranial nerve does not close the eyes. Got my point? If the problem is there in fifth cranial nerve, because अगर afferent information नहीं गए तो efferent दोनों तरफ नहीं जा सकता. Suppose if afferent is fine, but you have a problem in efferent, that is seventh cranial nerve, then what will happen? If you touch, information will go to brainstem. This side it want to close eye, but there is a block, but the other side will close. Then where is the problem? फेशियल नर्व में प्रॉब्लम आया या नहीं है समझ में? अभी मैं पूछता हूं. I touched this side, doctor, with a cotton swab. Both the eyes are not closing. Which eye this is? Left eye. Left eye, right eye. When I am touching with cotton swab, both the eyes are not closing. There is a lesion. Left, super. If I am touching right eye, right eye is not closing, but left eye is closing when I am touching right eye. Where is the lesion? Right facial. Okay. So in the figure, hemiparesis is to the opposite side of lesion, and the patient is having a gaze towards the opposite side. So where is the which is the structure which is involved? So fundamentally it all depends upon your once more anatomical knowledge. Where is medial longitudinal fasciculus? Where is peripontine reticular formation, etc., etc. The same story. Then once more, there are lesions in pupillary light reflex. So what are the structures involved? So fundamentally you must know what is the pupillary pathway. Okay, give me the board. There is retina, doctor. You have thrown light on the retina in one eye. There is an optic nerve which is going and become optic chiasma. So as optic chiasma, when it is passing as optic tract, what will happen is at the level of the midbrain, it leaves some fibers which will go to a place in the midbrain called pretectal nucleus. From pretectal nucleus, the fibers go to ipsilateral Edinger-Westphal and contralateral Edinger-Westphal. From Edinger-Westphal, the fibers will go to ciliary ganglion. Ciliary ganglion. And from ciliary ganglion, ciliary nerves will come and they supply the sphincter pupillae. Sphincter pupillae. अभी बताओ, आपने लाइट डाला, रेटिना को स्टिमुलेट किया, तो वो ऑप्टिक नर्व से जाके chiasma बन के प्रीटेक्टल न्यूक्लियस पहुंच के दोनों तरफ की एडिंगर-वेस्टफॉल को गया. From Edinger-Westphal it went to ciliary ganglion and constricted this pupil, and from the contralateral Edinger-Westphal also it went and constricted this pupil. So if you throw the light, what happened? Same side pupil constricted, opposite side pupil also constricted. Opposite side pupillary constriction is called consensual light reflex. So this is the story of what? Pupillary light reflex pathway. What are involved in this? Retina, optic nerve, pretectal nucleus, Edinger-Westphal of both sides, and then ciliary ganglion, short ciliary nerves, and then they go and supply the sphincter pupillae. Khatam? Huh? We will discuss more detail on Monday, because pupil defects, ID pupil, Horner's pupil, Edinger-Westphal, ID pupil, Horner's pupil, Argyll-Robertson pupil, 4 different varieties of pupils are favorite question of the examiner in DNB. There is a tumor sitting on the pineal gland. What is that? It is called as Parinot syndrome. Okay, that is compressing the midbrain. So what are the clinical features of Parinot syndrome? It is also called dorsal part of the midbrain got compressed by a mass at the level of the midbrain. Generally a mass at the level of which midbrain will be a pinealoma. So you get impaired upward gaze because you are having the center for vertical gaze located in the midbrain. Pupillary dilatation, midbrain is the place where pretectal nucleus, blah 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 are there, no? So if they get compressed, what will happen? Fibers ultimately from pretectal nucleus will go to Edinger-Westphal to sphincter pupillae. So if sphincter pupillae is paralyzed, dilator pupillae is unopposed. That lead to pupillary dilatation. Then there is lid retraction, convergence, nystagmus, dissociated near light response. All these features are the features of Parinot syndrome is what need to be remembered. Now you have got the various combination of clinical features and what is the diagnosis. So typically you are having a medial pontine syndrome as a clinical feature suggests, which occur because of basilar artery occlusion. Then once more you have some set of clinical features which are being projected. So what do you have? Medial medullary syndrome of Dejerine, right? So if you are unable to answer this question still, go back to the DNB general medicine discussion. In that we discussed in great detail all brainstem syndromes. You remember ना? हाँ? तो मैं बताने के बाद भी अगर आप रॉन्ग करें तो मेरे क्या बोलते हैं कसूर है मेरे कसूर नहीं. हाँ? तो then in the figure which is being shown, you are having all the clinical features of lateral medullary syndrome of Wellenberg, which is often because of the vertebral artery and the branch of it, which is posterior inferior artery. Then doctor, what is the arterial supply of pons and midbrain was the question. So superior cerebellar artery, anterior inferior artery and basilar artery, how do they supply the pons? You must be quite sure. Rostrally supercerebellar, caudally antereinferior cerebellar is the typical blood supply, and basilar artery will give paramedian branches that ultimately supply the horns. Then once more you get a cut section of the various areas. What is the blood supply? So you have long circumferential branches of the posterior cerebral artery. There is a medulla blood supply. Then you have posterior communicating artery, you have posterior cerebral artery, and you are having the different branches which are supplying, this is the midbrain blood supply. Then you have loss of position and vibration, spastic paraparesis and happening. So what is this? Where do you see this combination? Typically when there is a loss of position and vibration along with spastic paraparesis, means corticospinal tract, upper motor neuron is involved. So combination of pyramidal tract and a sensory tract. Pyramidal is what? Motor tract. Corticospinal is what? Pyramidal tract. Which is a motor tract. Along with demyelination of dorsal columns, everything is there, which is a sensory tract. इसलिए इसको क्या बोलते हैं? Combined degeneration of spinal cord बोलते हैं. What is combined about it? एक pyramidal tract जो corticospinal होता है मोटर, और एक sensory tract, दोनों का involvement है, इसलिए इसको combined degeneration बोलते हैं. Then doctor, loss of position, vibration, spastic paraparesis along with ataxia. Where do you see, doctor? Typically in Friedreich's ataxia. Then loss of position, vibration along with deep tendon reflexes, there is a loss. Urinary incontinence is also there, and there is a lancinating pain of the extremity. What is this combination called? Tavis dorsalis. Then there is a flaccid paralysis at the level of lesion and spastic paralysis below the level of lesion. At the level of lesion, LMN type. Below level of lesion, UMN type. That means there is a level that happened, which typically happens whenever there is, lower limbs, UMN features, upper limbs, LMN features. Combination is found in amyotrophic lateral sclerosis. Okay? Who is the great man who had amyotrophic lateral sclerosis? Stephen Hawkins. And there is a recent movie that is Hollywood movie on that. Very well, very good movie. So, distal upper extremity sensory loss, distal upper extremity weakness. So, where do you find? Which lesion possibly it is out of all these lesions? So, it is also called central spinal cord injury. So, that is the reason it is the lesion D, where central spinal cord injury is being shown. Okay. Then you have quadriparesis, loss of pain and temperature below the level of lesion. So, what is the possibility in this given case? It is an example of anterior spinal cord syndrome, because in the spinal cord, anterior aspect is all motor, posterior aspect is all sensory, is what you have to understand. Ipsilateral loss of position, vibration with ipsilateral hemiparesis with contralateral loss of pain and temperature, classical of hemisection of the spinal cord, which is basically called as the Brown-Sequard syndrome. Loss of vibration below the level of lesion along with paraplegia, along with the loss of pain and temperature below the level of the lesion, along with autonomic disturbances. Then what is the possibility? Typically it is a case of transverse myelopathy, which is associated with that combination.